Hello, my name is Sam Feltham and welcome to Expert Interviews here on Smash the Fat. With me today is a guy that I didn't know that much about, but he commented on one of my YouTube videos, one of the expert interviews, in fact, the Dr. Eric Westman interview on debunking low-carb myths, and then it turns out that he's one of the experts on Jimmy Moore's Keto Clarity book as well, and he is also a type 1 diabetic, so it's very eloquent that he's going to be talking about low carb diets for type 1 diabetics today. It's Dr. Keith Runyan. How are you doing, Keith?
I'm great, Sam. How are you?
Fantastic. As we were chatting about before, the weather isn't too great either here in London. It's kind of around about 15 degrees Celsius, or that's kind of around about, I think, 65 degrees Fahrenheit, maybe 70, I'm not sure. And how cold is it in Florida? Because apparently it's not too hot there either.
Well, it's all relative, right?
So, yeah, exactly. It's hotter than here, but it's not as hot as it usually is.
We're in the low 80s.
Low 80s, okay, yes. Okay. So you're kind of more like about 23 degrees Celsius, kind of nice room temperature kind of style. Cool. Right. But as I said in your introduction there, I wasn't really aware of your work before, but then you kind of commented on my Dr. Eric Westman interview, and then it turns out that you're one of the experts in Jimmy Moore's Keto Clarity, and then I read through all of the articles on your website, which is a great resource, and the website address for that is drkrunyan.com, so drkrunyan.com, and people can check out Keto Clarity at smashthefat.com/Keto UK if you want to buy it in the UK, or smashthefat.com/Keto US if you want to buy it on Amazon US. And you've had quite an interesting journey, going from where you were as a nephrologist, which is a specialist in kidneys, and being a medical doctor, to actually starting to use low carb diets for type 1 diabetics, and yourself as well. So can you tell us a bit of a backstory about how all this happened?
Yeah, I got diabetes type 1 in 1998 when I was 38 years old, and that's called latent autoimmune diabetes in adults. Wow. So it's kind of a variant of type 1 diabetes. Anyway, so I got started immediately on insulin and followed the usual recommendations of the endocrinologists and the American Diabetes Association, followed the diet they recommended and took the insulin. I checked my blood sugar frequently, and my hemoglobin A1C usually averaged around 6.5 to 7, which is exactly where they recommend it to be. The problem I had was hypoglycemic episodes, and obviously if you've never had one, it's hard to really understand how awful they are. Mm-hmm. But I just felt like it was part of having diabetes, and I just accepted it. So then in 2007, I decided, since I was not exercising on a regular basis, that my health might be improved if I start exercising. So I picked triathlon based on my wife starting it, and she seemed to like it, and I went to one of her events, and it looked like a lot of fun. So I decided to start swimming, biking, and running. And what I learned was that the other triathletes were using these sports gels and goos and things during their exercise, before, during, after. It seemed like a lot of sugar, and I figured, well, I have this potential to have a low blood sugar while I'm exercising from taking insulin for type 1 diabetes. Maybe it would be a good idea to have some sugar as I go. So I did that, and over time, what I began to realize was that my actual blood sugars were getting higher from taking the sugar for the exercise. And my hemoglobin A1C reached a peak of 7.9 after doing that. And I said, boy, this doesn't seem right. I'm doing this exercise for my health, yet my blood sugars are higher as a result. So then I got the idea, well, you know, I'd also like to do this Ironman triathlon. It seemed like sort of the pinnacle of the sport, you know, to test your endurance and your, you know, I just thought it was a challenge. Mm-hmm. And I said, but if I'm having these high blood sugars and then going to go do an Ironman, I need to find out more about this. Well, about the same time, I actually heard a podcast while I was on my bike trainer from Lauren Cordain. And that was the first time I'd ever heard, despite all my medical training, that nutrition actually can, or poor nutrition can actually cause diseases. That concept was never actually introduced to us, isn't it?
Yeah.
So then that, well, first of all, I got started shortly after on the paleo diet. But I did notice that, you know, my blood sugars really didn't change a whole lot. And so I looked further into it. Then I got on Jimmy Moore's website and listened to his podcast. And then I heard a podcast by Richard Bernstein, where he manages
the godfather of low carb diets, pretty much.
Yes, yeah, he manages type 1 diabetes with a ketogenic diet. Mm-hmm. He doesn't emphasize a lot this aspect of ketogenesis in the book. He just sort of says to limit your carbohydrates to 30 grams a day. And he has a lot of other information that was very helpful to me. And so I started the paleo diet in November of 2011, and then once I understood what was going on, and I had read Good Calories, Bad Calories, and Dr. Bernstein's book, and some other books too, I started on the ketogenic diet in February of 2012. So what happened was I had an immediate lowering in my blood sugar, and my insulin dose was dropped in half within a week or so.
Wow. That's
yeah.
That's incredible.
But even better, what happened was I stopped having the hypoglycemic episodes.
Wow.
So in the first 6 months on the diet, I had only 2 episodes. Now these episodes is what I'm describing is where you start sweating profusely and your mind is not working correctly. You sometimes I wasn't even aware that that was the cause of my sweating. You know, I'd say, well, it must just be warm in here, and I'd turn a fan on and stuff like that, because your brain is not really working because it's lacking energy, it's lacking glucose. So by changing over to this ketogenic diet and relying on fat for my body and ketones for my body, and particularly ketones for the brain, it now has a new source of energy and is not so dependent on glucose. So that when the blood sugar does drop, and you know, it's sort of a part of having diabetes is that there will be times where the blood sugar gets low. Anyway, so when that happens though, the brain is not starving for fuel. The sympathetic nervous system is not stimulated, so I didn't get sweating or tachycardia or heart pounding in my chest, and my mind was working perfectly. So this is the part that I want to emphasize most, because it's not really mentioned in Dr. Bernstein's book at all. And I'm not sure why, whether that was some liability thing or what. And I'm not saying that everybody who attempts a ketogenic diet will have this response. But what I'm saying is that I started it and I followed it very strictly. I've never had a cheat day once. So wow. I've checked my blood ketones 77 times, and only 4 times was at less than 0.5.
There you go. That's good.
Yeah. So the highest ketone I've ever had was 6.9, and that was at a time when I was exercising a particular increased amount, and my insulin dose had dropped. So remember, insulin regulates ketones. That's why in a diabetic who's taking insulin, they don't need to worry about diabetic ketoacidosis because they're taking insulin. So insulin is the regulator of ketones. Insulin is the regulator of diabetic ketoacidosis. So as long as you're not ill and you're taking your insulin, you won't have diabetic ketoacidosis. Anyway, so at that particular time when the ketones were 6.9, my total insulin dose for the day was 15 units, which is significantly less than my usual. So my usual is anywhere from 25 to 30 units a day.
Right.
All right. So anyway.
And just to put that in perspective, sorry.
I'm
Doc,
sorry. Yeah, I forgot.
Like for say somebody that's on a standard American diet and is type 1 diabetic, how much insulin international units will they be taking?
Yes, just like me, about the average for a lean type 1 diabetic around 150, 160 pounds would be about 55 units a day, which is exactly what I was on. So I was on the usual, and so basically it dropped to around 24 within that first week, and then since then I've actually gained weight since then. So in February 2012 I was 153 pounds. Now I'm 170 pounds. But
that sounds healthier to me. That sounds healthier to me, though, because that's a common problem with type 1 diabetics is they lose weight really quite rapidly, right?
Right. Yes, and that was actually my presenting problem with type 1 diabetes. Is I started at a normal weight and I had lost a lot of weight. But anyway, so back to the ketogenic diet. Now, so in that first 6 months, I had 2 episodes with symptoms. And then, so now it's been 2 years since then. I've been on the diet for 2.5 years. I've had no symptoms of hypoglycemia in the past 2 years. And I can't really describe to you how fantastic that is for me. Now, here's the other part. It didn't happen rapidly, and I'll tell you why. But for the last 9 months, my hemoglobin A1C has been 5.0.
Steady.
Nice. Now that's like normal, and it's very unusual for a type 1 diabetic eating carbohydrates to have a normal blood sugar. So my average blood sugar over that same period of time has been 84, which in your units would be 4.6 millimolar, and so I basically have normal blood sugars and no hypoglycemic episodes by following a ketogenic diet very strictly.
That's fantastic.
I feel great. And by doing that, I also was able to do the Ironman triathlon without having to eat any sugar, any food. I just drank water and I think some chicken broth that was provided at the aid station.
Nice.
So, yeah. So it's really changed my whole perspective on life. If you can imagine, when you have type 1 diabetes, you're sort of expecting to have certain complications. You're sort of expecting to have a shorter lifespan. And at this point, I have no complications. And I don't feel like I'm going to live a shorter life now that my blood sugars are normal and I'm not having these hypoglycemic episodes. So that's why I put that comment. Actually, it wasn't on Dr. Westman's. It was on Stephanie Person's interview, because she specifically said that if you have type 1 diabetes, you shouldn't be on a ketogenic diet. She didn't explain why, but I thought, anybody who may have heard that might be dissuaded from trying it. And what I really wanted to tell you is the main message is that it's perfect for type 1 diabetes. And then one last thing is to emphasize again that you're not at increased risk for having diabetic ketoacidosis as a result of a ketogenic diet. Nutritional ketosis is completely different than diabetic ketoacidosis. So just to repeat one more time, diabetic ketoacidosis is usually in patients with diabetes who have a severe infection. The infection releases stress hormones like cortisol, growth hormone, epinephrine. Their blood sugar goes up. They often get ill, and then because their blood sugars go up and they're ill, they don't really know how to treat their illness, so they actually stop taking their insulin. Those are the people I saw in the hospital many times over the years. The other group are people who have some financial difficulties, or they're just simply irresponsible, and they just stop taking their insulin. Now, people listening to your show probably would be in neither of those categories. So I just want to emphasize that this diet does not increase your risk for having diabetic ketoacidosis at all.
Yeah, it's absolutely fine. Almost two completely different things as well. Now, just to give the kind of listeners and viewers kind of a real idea of kind of why people initially kind of think that a ketogenic diet isn't suitable for somebody with type 1 diabetes. It's usually because type 1 diabetics have a problem producing insulin, and people think that because you're going on a ketogenic diet and you're bottoming out your insulin, then you're going to have problems, and then they start to go in this sort of thinking that the people are going to go into ketoacidosis and so on and so forth. But obviously kind of the work by Dr. Bernstein and kind of, your experience and your knowledge has kind of shown that that isn't quite the case. So what exactly is going on here in terms of kind of the conventional wisdom and the reality of the situation?
Okay. Well, a ketogenic diet restricts carbohydrates, and depending on the types of foods you choose, it could be anywhere from 30, like Dr. Bernstein recommends. I actually eat more carbohydrates because the vast majority of my carbohydrates come from non-starchy green vegetables. I eat an entire plate of non-starchy green vegetables for dinner. So those have a lot of fiber, and so therefore the total count is higher. But the reduction in carbohydrates is the reason that a type 1 diabetic needs less insulin, because carbohydrates are the macronutrient that require the most insulin to dispose of them properly. Protein is number 2. Protein takes some, but let's just, I don't know an exact number, but let's say 1/10 the amount of insulin to process a gram of protein compared to a gram of carbohydrate. And as far as I can tell from the literature, fat is basically a freebie in terms of insulin requirements. So what you've done is you've restricted the one macronutrient that has the most insulin requiring effect. And that's why the insulin doses are lower. Now, another important aspect of this is the reason that taking a lot of carbohydrates and trying to match it with insulin, the reason it doesn't work is because there's a high variability in the amount of glucose absorbed from carbohydrate foods. One paper I read estimated as much as a 50% variation from food to food, meal to meal, day to day. Mm-hmm. That's a huge variation. So if you're trying to match insulin doses with carbohydrate, you're going to likely be wrong much of the time. In addition, when you inject insulin, there is a variability of up to 30% with how much insulin actually gets absorbed from where you injected it. That's also written up in papers. So now you take two big variables and combine them together, because the more carbohydrate you eat, the more insulin you have to take. So you're increasing the variability of both of those variables. That's what leads to this hypoglycemia and hyperglycemia in patients with type 1 trying to eat a lot of carbohydrates as recommended. So by reducing those carbohydrates, you've reduced a big variable, and by decreasing the insulin, you've reduced another variable. That's why this works so well. So the reason that you can have a normal blood sugar is because you're not having spikes that go high, and you're not having lots of lows. And then because of the ketosis, when you do have a low, your brain is working, you're not sweating and having to change your clothes, and you can then take a very small dose of glucose. I use a glucose tablet. It contains 4 grams of glucose. That's it. Now, interestingly, though, 4 grams of glucose is enough glucose to fill up your whole bloodstream with glucose.
Yeah.
So, although it seems like a tiny amount, the body does not like a lot of glucose running around in the bloodstream. No. So anyway, a very tiny dose of glucose will fix a low blood sugar, and nobody else around you is going to know that you even had a problem because you feel fine, you're acting fine, you're speaking, you're not sweating. So you just take your little glucose tablet when and if that happens, and it's all good.
That's fascinating. That's absolutely fascinating. I didn't know about kind of a 4-gram glucose pill, because that's literally a teaspoon, isn't it?
That's right.
Almost like a level teaspoon, and that's how much sugar we have in our blood. People often kind of forget that. So if you're kind of eating, say, a big bag of chips or having a can of soda, you know, you're having about, what was it? I think it's about 30 grams right there.
Yep.
And
it's about 32 in a 12-ounce Coca-Cola. So that's 8 times as much sugar as in your blood. Now that's assuming that all that sugar in a Coke is glucose, and that's really not the case. It's half glucose, half fructose. Mm-hmm. So just as a technical point, I would like to emphasize that diabetics should be in the habit of carrying glucose tablets. They're available at all the pharmacies, at grocery stores. They're a little more expensive. But because they're pure glucose, you don't have to take as much. You take half as much as you would if you were taking table sugar, that sort of thing. So it's best to use pure glucose. But, you know, of course, if you're in a pinch and you don't have them with you, then anything sweet would raise the blood sugar. But it is a good habit to use pure glucose, not the sucrose or high fructose corn syrup that you would find in a lot of the products around.
Certainly, and being able to kind of take that in a pill form is kind of useful as well, because it's all kind of measured beforehand, and you know exactly how much is kind of going in there as well. Exactly. Cool, that's fascinating. So, kind of on a day-to-day basis, what does your daily diet look like, along with kind of your insulin regime?
Okay. Well, for breakfast, I have some sort of meat. Usually, it's salmon. But sometimes bacon, sometimes eggs, sometimes some other leftover meat from the night before. And then I have olives, sometimes a little vegetable. Like this morning I had a few little baby carrots, raw carrots, and a few celery sticks. I vary it from day to day. I put half of a lemon squeezed on the salmon when I have salmon. And then I have black coffee with coconut oil and sometimes cream as a treat, although I don't have cream every day. The coconut oil, I'll just quickly mention, is rapidly converted to ketones. So I've used that in the past to try to increase my ketones just to see how high they would go. And that time I quoted you about a 6.9 millimolar ketone, that was when I was taking coconut oil 4 times a day as an experiment. So they're typically not that high, and I typically don't eat that much coconut oil. All right, then what I do is I don't eat lunch. I learned that years ago as a way to avoid hypoglycemia, because every time you take insulin, there's always a chance that your blood sugar will be low or high before a meal. So I just figured, well, if I just skip the meal, I won't have to deal with that. And then at dinner time, again, it's about the same idea. It's some kind of meat, and then a whole plate of vegetables. And on those vegetables, I'll put butter. And then for dessert, I'll have some nuts. Not a huge amount, but macadamia nuts, Brazil nuts, and pumpkin seeds or pepitas. Those are my three favorite because they're the three that are lowest in carbohydrates. They have lots of vitamins and nutrients also. Now, if I don't have cooked vegetables, I'll have a salad, but again, I'll put lemon juice or some vinegar, balsamic vinegar, and then olive oil. So with everything I eat, I make sure I have some fat with it.
So yes, it's so important that people do get fat with their meals. Not just for type 1 diabetics, but for people without any kind of medical conditions as well. And kind of we've been going through this low fat craze that's still kind of around a little bit. You see TV commercials and adverts all the time in terms of them bragging about that it's 0% fat yogurt, it's a metabolic disaster, basically, that is, isn't it? So yeah, that's fascinating about your daily diet. And when do you kind of time your insulin with that? Is there any kind of specific times that are different to kind of what type 1 diabetics are usually told, and in terms of kind of changing where you inject as well, are there any kind of differences with that?
Yeah, there's one difference, and that is I never inject more than 7 units of insulin at any one time. Mm-hmm. So if I have to take for instance, my long-acting insulin, which I use Lantus, I take 11 units in the morning and 12 in the evening. So I split those into 2 doses and inject them in separate locations. Again, that came from another study as well as Dr. Bernstein's recommendations that that decreases the variability in absorption of the insulin when it's injected as a small dose. So that is one difference compared to what I used to do. Mm-hmm. And it's not so much related to carbohydrates. It's just another technique to try to improve glucose control with diabetes. So small insulin injections, and of course the fact that the carbohydrates are lower means you don't have to have as many of those separate injections. You know, some patients with diabetes don't like to give injections, and to be honest with you, I think that if they want to be healthy and not have these hypoglycemic episodes and not have complications, an extra injection or 2 a day is certainly worth it, especially if you know how to inject it, which is to inject it rapidly. And the needles are so small nowadays. They're 31 gauge or sometimes 32 gauge, depending on what your pharmacy has. It's you can hardly feel them. So, you know, people I think need to get past the idea that giving insulin injections is something that's painful. It really isn't.
Yeah, it's almost like just slides right in.
Yeah. I mean, sometimes you feel it, and sometimes you can't even feel it at all. So,
absolutely. And sorry, what were the injection sites? Kind of the differences there?
Okay. Well, there is an important difference. The insulin is absorbed most rapidly from the abdominal area, and it's the thighs and buttocks are less rapidly absorbed. And so sometimes you can use that difference to fine-tune the blood sugar control based on the type of insulin you're using. I used to inject it in the thighs, and then I changed over to the abdomen, and since everything's working right now, I just sort of kept it there. But that is an important point, is that there can be differences in insulin absorption from different sites of injection. The shoulder, the side of the arm, upper arm, is another injection location and that's kind of intermediate in rapidity of absorption between the abdomen and the thighs or buttocks.
Absolutely. And you recommend sort of through the abdomen in small doses to get it rapidly into the system for yourself?
Well, I'm not recommending that specifically for other people. I'm just saying that that's what I'm doing and that's what works for me. But like I said, that knowing that information, that the absorption rate varies depending on where you inject it, might help a diabetic patient, along with their doctor, on maybe making some changes that might improve their glucose control.
Absolutely, it's something that obviously they should discuss with their diabetologist or just their physician who's in control of their doses and whatnot. And is there kind of any resources that people can kind of go to really get the nuts and bolts of using a ketogenic diet for type 1 diabetes?
Well, there are quite a few resources. As a matter of fact, I've written a book with Ellen Davis. She's from the ketogenicdietresource.com website, and that should be out by the end of the year, at least in an ebook form. And so that will be one resource. And there's also Dr. Richard Bernstein's book, which I recommend. And then in terms of understanding the basis for this low-carbohydrate diet, if people are really sciencey, Good Calories, Bad Calories, I recommend. And then Steve Finney and Jeff Volek wrote The Art and Science of Low-Carbohydrate Living and The Art and Science of Low-Carbohydrate Performance if they're interested in sports. So there's lots of resources, and one other point is I think it's best if patients go talk to their doctor about it and try to get their doctor on board. I've told patients, who've emailed me to get one of these books and give it to their doctor and ask them to read it as an assignment before their next appointment. Try to get their doctors on board, because if you survey all the doctors, many of whom you've talked to, as to why they advocate this approach, it's because they actually had a personal experience with it, either for themselves, that's the majority, but there are other doctors who started using it in their patients and saw excellent results. And when a doctor sees excellent results, it's hard to deny that it's appropriate for their patients. So if they give their doctor one of these books and tell them they want to do this diet and they want help with it, their doctor might be motivated to look into it and reap the benefits, and then that doctor can then use it with their other patients. And then this can explode and be leveraged to many more people. So that would be my recommendation, is to get your doctor on board and get them to help you.
Fantastic. Very wise words from Dr. Runyan, for sure. And there's just one more thing for us to do, Doc, and that's to hear a smash it out from Dr. Keith Runyan. So on 3, I want you to shout smash it out to the camera. So 1, 2, 3.
Smash it out!
Awesome! There we go. That is fantastic, Doc. I really, really appreciate that. And people can check out Dr. Runyan's website, as I said at the beginning, at DRK Runyan. That's RUNYAN.com. Follow him on Twitter at Keith Runyan MD. PhD, and also be sure to check out Keto Clarity, which he's an expert in, and we'll get him back on the show for the written book that's going to come out kind of Christmas time. But if you want to check out Keto Clarity in the meantime, you can buy it from Amazon, either from smashthefat.com/keto UK or from Amazon US via smashthefat.com/keto US. And was there anything else that you wanted to share with our listeners and viewers at all, Keith?
Well, not specifically, but I really enjoyed talking to you today, and I feel very glad that you are doing what you're doing to try to spread the word, because there is nothing more powerful in treating medical problems and in achieving health than the food that you eat. And I just would like people to hear that from a doctor who was never taught that, but found out through other means, like people like you, Jimmy Moore and other podcasters. When they're able to teach a physician, it's a bit ironic, but however you get the information, that's what matters.
That's right. As I kind of always say, and I don't mean to demean the profession at all, is that I prefer to listen to what somebody has to say rather than read the letters after their name. It's kind of the most important thing. They can have as many letters after their name as possible, but they might not make any sense at all. So just listen to what somebody says rather than read the letters after their name, I suppose.
Yes. Well, I'm optimistic that in the future that will change. I think that nutrition needs to be an important part of a medical education.
Big time.
I think one day it will be, and then you won't have to make comments like that, which is true. But that's just because doctors were not educated properly.
Precisely.
In this area. So.
Yeah, that's it. And hopefully, that'll completely change, and then we'll feel completely entrusted with the conventional medical profession, which would be fantastic. And we'll get there one day, I'm sure, Doc, for sure.
Yes. Yes.
So again, thank you so much for your time.
Okay. All right.
I really appreciate it. And we'll get you back in Christmas to talk about that book.
That would be great.
Fantastic. Thanks a lot, Dr. Runyan. Take care.
Have
Bye
a
now.
good day. Bye-bye.
You too.